finally, we sit down with Dr. Sara Tolaney, who is the Associate Director of the Susan F. Smith Center for Women's Cancer, Director of Clinical Trials, Breast Oncology, Senior Physician, and Assistant Professor of Medicine at Harvard Medical School. Hi, Dr. Tolaney. We're so happy to have you here today.
Oh, thanks so much for having me.
Sure. So towards the end of this year's meeting, we saw a huge number of breast cancer abstracts, saw the readout of them. Can you share what ones stand really out to you in 2019?
I think one really exciting abstract that we saw were the results of the MONALEESA-7 study. So this was actually the only phase 3 trial specifically for premenopausal patients that looked at the benefits of adding a CDK4/6 inhibitor to endocrine therapy. So in this trial, women were randomized to receive physician choice endocrine therapy. In essence, they all had to get ovarian suppression, but then could get either tamoxifen or an aromatase inhibitor, and then got randomized to receive ribociclib or placebo. And we've previously seen the results regarding progression-free survival, suggesting an improvement from around 13 to almost 24 months, which is very consistent with all the trials we've seen in postmenopausal women in terms of this very impressive improvement in progression-free survival. But what we saw today, actually, at ASCO was the overall survival data, which I think was very impressive. So it's the first study looking at overall survival that's actually had a statistically significant benefit. So what we saw was that there was a 29% reduction in deaths from the addition of ribociclib to endocrine therapy. Again, this is specifically in a premenopausal population. That being said, they are all rendered postmenopausal, and so it does make you wonder if this is something that is going to be a generalizable phenomenon to the other trials, and so we're eagerly awaiting the data from the studies that looked at postmenopausal patients.
Good, okay, great. Now, in HER2-positive disease, we saw some data from the SOPHIA study with margetuximab and chemotherapy, which has been showing some promising activity compared with trastuzumab. So what's your thoughts on these data?
So this trial, the SOPHIA trial, randomized patients to receive chemotherapy with margetuximab or chemotherapy with trastuzumab. So margetuximab is a very interesting drug. It's a monoclonal antibody that's directed against HER2, just like trastuzumab is, but it has an FC optimized region, so that has increased affinity to CD16A. This is something that trastuzumab actually has a little less affinity to, and so the thought would be that potentially this agent may actually enhance ADCC, increase NK activity, and so may have some increased immune effector function. And so this study did show that there was a statistically significant improvement in progression-free survival. That being said, the difference was small. It was only about a month. And so I do think we're very interested in seeing what the overall survival data says when that is mature. But it does give us a hint that this agent may potentially offer some advantages over trastuzumab, particularly in those patients who have the CD16A F genotype, where we did see that there was even an incrementally larger benefit from the use of margetuximab. And so again, I think we need a little bit longer follow-up, but I think very exciting data.
Good, okay, great insight. Now, also in HER2-positive breast cancer, we learned about the NALA study, which is looking at neratinib and capecitabine in the metastatic setting. So could you discuss these data?
Yeah, so neratinib is an agent that we've had around now. It is FDA approved for extended adjuvant therapy, where it has shown benefit. This study specifically was looking at adding neratinib to capecitabine and comparing it to capecitabine with lapatinib. And so what we found was that there was an improvement in progression-free survival with a difference of about 2.2 months favoring capecitabine and neratinib. But what I think was also interesting was that there was a delay to time to CNS intervention for patients getting capecitabine and neratinib compared to the capecitabine-lapatinib combination. You know, we have some prior data that has suggested that capecitabine and neratinib does have nice CNS activity. There was about a 50% volumetric response when that combination was previously studied in patients with active brain metastases, but now this is really showing a delay to time to CNS intervention. And so I do think it potentially will be a combination that will be approved and available to patients. I think the challenge for us will be how to integrate this into practice, because there are now so many HER2-directed therapies in this particular setting, so in this sort of third line and beyond setting. And so then it becomes a choice of when do you use capecitabine trastuzumab, when do you use capecitabine neratinib, and then what about all the other options that we're going to be seeing in the near future. And so I think we'll be challenged with how to optimize to the sequencing of these agents. But I think particularly for a patient with CNS involvement, this may be a very attractive combination.
Great. Okay. What do you think the future really holds for CDK4/6 inhibition as a whole for breast cancer?
So I think CDK4/6 inhibitors have really changed the way we practice and the way we treat our patients with metastatic ER-positive disease. And I think given the data that we've seen, that's very consistent improvements in progression-free survival, and now data looking at overall survival that was positive in a premenopausal population, I think it suggests that patients with endocrine-sensitive disease really do derive significant benefits from these agents, and it should be standard of care. I think there's a lot of potential ways these agents could change practice in other settings too. There are ongoing studies looking at CDK4/6 inhibitors in the adjuvant setting. Both the Monarch E and Palace trial have completed accrual, and so we are awaiting that data to see if these agents will become available for that population. Penelope B also looked at using CDK4/6 inhibitors in patients who failed to achieve a pathologic complete response to preoperative therapy, and so again, we're awaiting those data. And I think we're also now left with the question of what do we do after someone progresses on a CDK4/6 inhibitor? And this is an area that we really are awaiting further data on. We did see at ASCO some data. One was from a study that looked at this, was the Trinity trial, which really looked at a triplet combination, exemestane, everolimus, and with ribociclib, which suggested a 5.7-month progression-free survival. It's just hard to know how that would compare to exemestane everolimus alone, since this was not a randomized trial. And so I think we really do need to see results from randomized studies to know whether or not there'll be benefit to continuing these agents beyond progression.
Good. Great insight. Now, just kind of taking a look at all these data that we've seen over the last couple of days, what do you think this really says about the future of breast cancer treatment?
I think it's so hopeful. There's so many new and exciting drugs that continue to come around. Even in the HER2 session, we saw data on margetuximab, paratinib, neratinib, and there's just so many new agents that continue to evolve, and even immunotherapy is seeing the survival benefit that we're seeing with atezolizumab in combination with nab-paclitaxel. So I think we're all very hopeful that we'll continue to improve outcomes for our patients.
Great. Well, Dr. Tolaney, thank you so much for being here today. We really appreciate you sharing your insight on all the breast cancer data.
Oh, thank you.
Okay.